A major problem in leprosy is the management of reactions that occur due to the immunological response of the body system against M. leprae bacilli. These reactions may occur before, during, or after the completion of MDT, in both PB and MB cases. Severity of reaction depends on the bacterial load in the body of the affected person and strength of immunological response. Long-term problems related to leprosy, deformity, disability, stigma, and suffering of the patient and their family are due to nerve damage from lepra reactions. Sudden onset of acute inflammation of skin lesions, nerves, eyes, and sometimes other organs in leprosy-affected person is indicative of reactions. Lepra reaction is diagnosed by clinical examination. Early diagnosis and prompt management can prevent disability and deformity risk for developing reactions. Though any person affected by leprosy can develop reaction, some are more prone, predisposed, at risk of developing reaction. Persons with following features are more likely to develop reaction. Multiple lesions, positive slit skin smear. Lesions close to the peripheral nerve, lesions on the face. Pregnancy and childbirth, hormonal changes, puberty, adolescence. Stress, physical, physiological, and psychological, intercurrent infection. Parasitic infestations. These patients should be monitored more frequently for early detection of reaction and its prompt management. Types of lepra reactions. There are two types of lepra reactions. Type I lepra reaction, also called reversal reaction, occurs in a patient with unstable CMI, both PB and MB. Type 2 lepra reaction, also called erythema nodosum leprosum, ENL, occurs in patients with MB leprosy with a high bacillary load. Type 1 lepra reaction. This may be the first presenting sign of the disease. It usually lasts for few weeks to few months, but in some patients can be recurrent. It presents with inflammation of existing skin lesions. Appearance of new skin lesions are in reality subclinical patches, now noticed due to inflammation. General condition of the patient is satisfactory. Usually there is no fever and patient does not feel ill. Inflammation of skin lesions. Signs of inflammation are seen in the existing skin lesions, i.e. skin lesions become red, more prominent, swollen, shiny, and warm. In severe forms, they may ulcerate. Lesions are usually not painful, but some discomfort may be felt. Sometimes, only few patches are inflamed. Inflammation of nerves. Nerves are frequently affected in type 1 reaction. Acute neuritis. Inflammation of the peripheral nerve results in pain, paresthesia, and loss of nerve function, sensory, motor, and autonomic. Neuritis may be the only presenting feature of reaction without inflammation in the skin lesions. Silent neuropathy/quiet nerve paralysis. Nerve function may get affected without any pain or tenderness of the nerve or inflammation of skin lesions. This needs to be identified early and treated promptly. Any nerve function impairment of 6 months duration is acute neuritis and requires treatment with steroid. Swelling of hands and feet. Swelling of the limbs and or face may be present as part of reaction. Eyes. Ocular tissue is not affected in type 1 reaction, but patient may develop corneal anesthesia and logophthalmos due to involvement of trigeminal and facial nerves. Type 2 lepra reaction occurs in patients who have a high bacillary load. It is a vasculitis due to precipitation of immune complexes in multiple organ systems, skin, nerves, testes, eyes, joints, lymph nodes, kidneys, liver, spleen, bone marrow. It may be the presenting complaint of the disease and usually last for few weeks to several months. General condition. General symptoms like fever, headache, and body ache appear before or along with the characteristic nodules that appear on the skin. Skin lesions. Type 2 reaction exhibits the typical signs of erythema nodosum: red, firm, painful, tender, subcutaneous nodules, about 1 to 2 centimeters across, of variable size, appear in crops. Nodules blanch on pressure. Usually multiple, they tend to be distributed bilaterally and symmetrically. They appear preferentially on cooler parts of the skin. They usually spare the warmer parts of the body, like hairy scalp, axilla, groin, and perineum. Rarely, they can break down and suppurate, necros producing erythema nodosum necroticans, ulcerative ENL. These nodule crops are evanescent, melting away in 7 to 10 days. When nodules fade, these leave bluish/brownish marks, followed by brownish hue in the skin. Unlike type 1 reaction, there is no clinical change in the existing leprosy lesions. ENL reaction may become chronic and persist for several years, causing significant debilitation. Eyes, ocular tissue may get affected. This may lead to iritis/iridocyclitis, inflammation of the iris and ciliary body, synechia, glaucoma, and impairment of vision. Eye becomes red, watery, and painful, pupil becomes constricted and non-reactive. Color of iris becomes dull and patient complains of photophobia, pain in the eye when it is exposed to light. Involvement of eye is an emergency and needs immediate referral to higher center. Swelling of hands, feet, and face may occur. Involvement of other organs, osteitis, periosteal pain, especially tibia, myositis, muscle pain, tenosynovitis, pain and swelling of tendons, arthritis, dactylitis, lymphadenitis, epididymoorchitis, hepatosplenomegaly, nephritis, proteinuria, RBCs and WBCs in urine, neutrophil leukocytosis, and neuritis. Difference between type I and type 2 reactions. Features: type of hypersensitivity. Type 1, reversal, delayed hypersensitivity, type 4. Type 2, ENL, antigen-antibody reaction, type 3. Features: skin. Type 1, reversal, few or many skin lesions suddenly become reddish, swollen, warm, not usually painful and tender. The rest of the skin is normal. Type 2, ENL, transient, red, painful, tender, subcutaneous nodules, ENL. Appear in groups, commonly on face, arms, legs, and are not related to patches. Features: nerves. Type 1, reversal, acute neuritis, pain, paresthesia, tenderness, swelling, loss of function, sensory, motor, autonomic, occurs commonly and acutely. Type 2, ENL, nerves may be affected but not as common or severe/acute as in type 1. Features: general condition. Type 1, reversal, good, occasionally mild fever. Type 2, ENL, poor, with fever and general malaise. Features: eye. Type 1, reversal, logophthalmos and corneal anesthesia due to neuritis. Type 2, ENL, iritis, iridocyclitis. Features: other organs. Type 1, reversal, rarely affected. Type 2, ENL, other organs like joints, bones, testis, kidney may be affected. Management of reaction. It is very important to reassure the patient and explain that it can be controlled with proper treatment. Type 1 leper reaction. The patient will need corticosteroids in addition to rest and analgesics. The drug of choice is prednisolone. The usual course begins with 40 to 60 mg daily in single dose, preferably in the morning after breakfast, up to a maximum of 1 mg per kilogram of body weight, and the reaction is generally controlled within a few days. The dose is then gradually reduced fortnightly and eventually stopped. Proper precaution should be taken in patients with diabetes, peptic ulcer, hypertension, tuberculosis, etc. Necessary precautions for administering steroid should be taken. Who schedule for prednisolone therapy for an adult patient in type 1? Reaction: 40 mg once a day for the first 2 weeks, then 30 mg once a day for weeks 3 and 4, 20 mg once a day for week 5 and 6, 15 mg once a day for weeks 7 and 8, 10 mg once a day for weeks 9 and 10, and 5 mg once a day for weeks 11 and 12. In case of neuritis, involvement of peripheral nerve, the period of treatment may be prolonged according to the response. From 20 mg onwards, the period for each dose would be for 4 weeks. Response to steroid therapy is generally seen within 2 weeks. Review the progress every 2 weeks. If there is no response, the same dose may be continued for further 2 weeks. If there is good response, the dose may be tapered according to the schedule. It is also important to provide rest to the affected nerve, if involved, until symptoms subside, by applying a padded splint or any suitable alternative material to immobilize the joints near the affected nerve. The aim is to maintain the limb in the resting position, to reduce pain and swelling, and prevent worsening of the nerve damage. Ulnar nerve elbow flexed to angle of 90 degrees. Median nerve wrist extended to 40 degrees. Common peroneal nerve knee flexed to 10 degrees. Posterior tibial nerve ankle in neutral position of 90 degrees. If a patient develops LEPR reaction during treatment, do not stop. MDT, complete the course of MDT. LEPR reactions, which occur after completion of treatment, should also be managed with steroids as per schedule. MDT should not be started again. Type 2 LEPR reaction, ENL. In case of reaction not responding to treatment after 4 weeks with prednisolone or at any time showing signs of worsening, the patient should be referred to the nearest referral center. Type 2 LEPR reaction mild, few nodules, mild fever. Treatment analgesics. Type 2 LEPR reaction severe, severe pain over nodules, tendency for ulceration, high fever, involvement of internal organs. Treatment steroid prednisolone course is given in the same dose as for type I reaction, but with faster tapering, given dose not exceeding 2 to 3 weeks. Type 2 LEPR reaction neuritis. Treatment prednisolone regimen as for neuritis in type 1 reaction. Clofazimine is also effective for type 2 reaction, but is less potent than corticosteroids and often takes 4 to 6 weeks to develop its full effects, so it should never be started as the sole agent for the treatment of recurrent type 2 reaction. However, clofazimine may be extremely useful for reducing or withdrawing corticosteroids in patients who have become dependent on them. The dose required in such cases is 300 mg daily, maximum of 1 month, which may be given in 3 divided daily doses to minimize the gastrointestinal side effects. It is tapered gradually to 100 mg daily. The total duration of clofazimine therapy should not exceed 12 months. Response will be seen after 2 to 4 weeks after starting the drug. Often, type 2 reaction may recur due to precipitating causes, like infection, stress, or helminthic infestation. LEPR reaction may subside faster or less likely to recur if precipitating factor is treated. For persons who suffer from chronic recurrent ENL reactions, not responding to conventional methods of management, thalidomide is drug of choice. But it is highly teratogenic. Treatment with thalidomide is only recommended in tertiary care hospitals after taking necessary consent. Since this drug is teratogenic, it is contraindicated for use in women of reproductive age group. Patient has to be followed up every 2 weeks while on steroids, general condition, side effects of steroids and nerve function assessment, NFA. Patient may need referral before starting the steroid therapy or during the treatment if they have comorbidities like hypertension, diabetes mellitus, peptic ulcer, tuberculosis, ulcers, and infections. Pregnant women and children under 12 years require special precautions when prescribing steroids.